Advancing Value Through Transformation. Good afternoon and welcome to the Healthcare Transformation Task Force's webinar series, Advancing Value Through Transformation. My name is Jeff Micklos and I am the Executive Director of the Task Force based in Washington, D.C. I will be your moderator today for our Transformation to Value, a Provider Perspective webinar. Before we begin the webinar, I will take a moment to orient you to the Zoom webinar platform. If you would like to ask a question to our presenters, or if you have a technical concern, please type your question or concern in the question box on the Zoom screen. Our team will be tracking the questions that arise, and during interludes in the presentation, we will select questions for presenters to answer. We will have a formal Q&A at the end of the presentation where you will have an additional opportunity to send in questions. This webinar is being recorded and will be posted to our website within 24 hours. With that, I'd like to get started by introducing today's panel. Again, my name is Jeff Micklos. I'm with the Executive Director of the Task Force, and I'm very pleased to announce our speakers today. We have two very accomplished provider leaders and important contributors to the Task Force's work. First off, I welcome Jason Dinger, Chief Incubation Officer at Ascension, the nation's largest not-for-profit health system. In his role at Ascension, Jason spearheads business development and planning efforts for new products and services. Prior to serving as the Chief Incubation Officer, Jason served as the Chief Operating Officer of Ascension Care Management and the Chief Executive Officer of Mission Point Health Partners. Jason holds a PhD from Vanderbilt University and is a co-chair of our Path to Transformation Advisory Group, which generated the work that we're presenting to you today. Great to have you here, Jason. I'm also very pleased to welcome Rick Gilfillan, the Chief Executive Officer of Trinity Health, a Catholic health system that serves communities in 21 states with 88 hospitals, 126 continuing care facilities, and home and health hospice programs. Dr. Gilfillan has been a leader in U.S. healthcare for more than 25 years in both the payer and provider sectors. He launched the Center for Medicare and Medicaid Innovation in 2010, and he is the inaugural chairman of the Healthcare Transformation Task Force. Rick earned his medical degree from Georgetown University and an MBA from the Wharton School at the University of Pennsylvania. Great to have you on the panel today, Rick. Thank you both again. We're very excited and honored to have you as our presenters today. Now for a brief overview of the topics we'll be covering today. We want to talk to you a bit about our Transformation to Value project and our framework, and then talk about two transformation stories related to Ascension and Trinity Health. The context for this conversation will be in four specific dimensions of transformation: strategy and culture, structure and investments, operations and accountability, performance management. I shall say that this is the first of two webinars in the Transformation to Value series. These will have provider representatives today, and at a future webinar we'll talk about at the end of the call, we will have the payer perspective represented in early November. A couple words about the Healthcare Transformation Task Force. Who we are. The Task Force is an industry consortium that brings together patients, payers, providers, and purchasers to align private and public sector efforts for the sweeping transformation of healthcare across the United States. Our provider and payer members commit to having 75% of their businesses operating under value-based payment arrangements by 2020. Next slide. We have a unique member composition. We call ourselves the 4 Ps, with the providers, payers, purchasers, and patients represented. And here's a picture of our current membership of 42 organizations. Next slide. And with that, I'd like to talk about the Transformation to Value project. For this, I will first turn it over to Rick for a moment to provide background on the Path to Transformation Advisory Group and the thinking that gave rise to this project and the output we're going to present today. Rick?
Thanks, Jeff, and good afternoon, everybody. It's great to be with you. And Jeff, thanks for the opportunity to join this webinar and talk about this notion of kind of the path to transformation. The origin of this was a number of us thinking about and talking about how it might be valuable for organizations to share their experiences as they kind of go down the road to trying to build their transformed entity, whether it's a provider system, a payer, or the experience of employers. And there's a lot of talk in a lot written at this point about the specific tactics, even strategies, and ways of going about producing more value. But what we felt was that there's not so much information out there about what the experience of an organization at the organizational, institutional level, what the experience is as that organization tries to transform itself into producing high-value services, care for our patients and for the payers. And so this was, think about it as more about us talking about at the institutional level, what does it take? What are the changes one needs to make? What are the lessons some of us have learned along the way? What are the successes? And most importantly, I think, is sharing with you our mistakes and what we've learned from our mistakes. So that was the purpose of this launching this new effort by the task force to look at the path to transformation. Jeff, do you want to talk about how the team has gone about setting up this work?
Sure, Rick. So we as an advisory group met and came up with a Dimensions of Transformation strategic framework, which we'll talk about in a second. And using that as our base, we went out and interviewed extensively 15 task force members falling into the categories of 3 payers, 9 providers, and 3 partners. And partners here are entities that guide providers through value transformation. And what we're presenting to you today is really the lessons learned, the commonalities, and the differences in the work that our members are doing. Next slide. So to set a context, this is our strategic framework. I think it'll be coming up in a second. Yes, this is our strategic framework. This is the base for all of our work. And the thought process that went into this is to recognize what are the key dimensions and subcomponent of those dimensions for an organization to go ahead and move into the value sphere. This is not a be-all or end-all. There's a recognition by our advisory group that we're finding that things that are the most important to start with and that you build out and become more mature over time. And so these break down into the 4 categories of strategy and culture, structure and investments, operations, accountability, and performance measurement. In the remainder of the webinar, we'll really focus on the lessons learned in each of those areas. And as we get into it, Jason will provide more detail on the particular dimensions. So before we get into the specific of lessons learned, we're going to ask our panelists today to each provide a thumbnail sketch of their respective organizations and their current tie and footprint in the value space. And with this, we'll start with Jason. Jason?
Thanks, Jeff. So I have the privilege of representing Ascension today, and as you can see from the slide here, we're a large health system covering quite a few different geographies in the Midwest and East Coast primarily. I think for the sake of this discussion, probably the most material importance is the level of diversity that we have in sites of care. So while traditionally known as a hospital operator, we now cover more than 2,500 different sites of care, from senior living to a number of hospice entities and other kind of wellness infrastructure that keeps entire populations well over the course of their lifetimes. And I think as we live into this notion of population health and the transition to value-based care, one of our key questions has been, what is that continuum of care that we need to offer our communities? How do we integrate those value-based care infrastructures to deliver great outcomes for our patients and great places for our people to practice at? And we'll talk more about that this later in the webinar. I think the other piece is, taking that diversity of care settings and then applying them against then a set of different initiatives, whether or not it's the shared savings program, CPC Plus, or commercial risk arrangements, we've really learned a lot on what to do and what pitfalls to avoid in delivering kind of comprehensive care across multiple geographies inside multiple programs, and we'll hopefully share some of those learnings as well as engage in questions and learnings that you've seen as well. And I think, you know, the power of the discussion today is not only to learn a little bit about our story, but to juxtapose that against some of the learnings that others have had. And so let me pass it over here to Rick to talk a little about Trinity and their story. Rick?
Thanks, Jason. So like Ascension, we are a large national not-for-profit Catholic health system. We're based in Michigan. We're in 22 states around the country. I think, I guess we should be clear that today's conversation is really about the lessons we've learned in our respective integrated health systems. Different lessons, I'm sure, from what some of our physician-based organizations, colleagues in the task force may have learned, and obviously, hopefully we'll have another time, Jeff, where we can provide that perspective. But I think I would just say to folks, keep in mind that the perspectives you're hearing about today are coming from folks who have had experience operating in these large integrated healthcare systems. They present a number of peculiar, I guess I would say, or at least particular challenges in this work, one being the connection to, the very direct connection to hospitals and other kinds of acute care facilities, and the second being a very large and therefore kind of a different management set of challenges to try and get new, novel, disruptive work like this done in our large organizations. So we've been involved in some of the same programs that Jason mentioned at Ascension. We have today about 1.3 million individuals for whom we're accountable for the AAA outcomes, including total cost of care. The total medical spend for that population is about $8.3 billion. About $500 million of that is in episodes of care with Medicare, final payment programs. And then the remainder is in a variety of Medicare, Medicaid, and commercial arrangements. Typically shared savings with some with upside only, about 20% with upside and downside. So fairly diverse experience you've had. And one of the lessons we learned, I would just say about that, and it's kind of fortunate in that we're kind of naturally diversified in terms of our risk profile as a result of being in different markets and dealing with different payers. We kind of have a natural diversification, which is, I think, is beneficial and good for you all to think about. You don't want to put necessarily all your eggs and all in one basket, or necessarily everything in something with a lot of downside. So that's our background, and happy to move on to the next section, Jeff.
Thanks, Rick, and thanks, Jason. So now we'll walk through each of the dimensions of transformation and get really into the meat of the webinar. As I indicated before, Jason will set us up by providing some more detail about the dimension and the inquiries in that dimension, and Rick will describe his organization's experiences as well. So as a reminder, we will have a Q&A at the end of the presentation, so go ahead and use your question box in the Zoom platform to let us know of your questions. I'll turn it over to Jason.
Great, thanks, Jeff. So I think that to start, it makes maybe a little bit of sense to provide some background. You know, we as a committee really spent a lot of time talking about what are the various dimensions that, you know, people need to kind of consider when delving into kind of value-based care. And as you can imagine, that was a wide-ranging discussion. What we're talking about is complicated, it's messy, and it tends to have its own unique nuances based on the type of organization you are, the geography in which you're in. And so I think one of the things that I'm most excited about as a deliverable to to you today is the general structure that we've put forth. And so you'll see that we've got 4 major dimensions, and then typically inside each of those we have 3 sub-dimensions. And I think our aspiration here is not necessarily that there's a right answer for each one of these boxes, but you should have a general orientation to each one of these sub-dimensions and major dimensions. And if you can be intentional about that, you're going to, primarily respond in a way that's close to the mark. And I think that's the first kind of takeaway for us, on this journey of Ascension, was really trying to understand what sub-dimensions do we need to really consider, and how do we want to respond to those, and how do those different sub-dimensions kind of support each other and hang together. And so I hope that while in some ways it's explicit today, that you can go back and take a look at the kind of wider structure that was presented on the earlier slide, and use that as a bit of a checklist, if you will, in asking, how are we thinking about these dimensions, and making sure that answers are both intentional and that they knit together. So that's I think the first takeaway. Now to kind of unpack that a little bit, what you'll see is we've got different slides here for each of the major dimensions and subdimensions, and I'm just going to briefly kind of talk through a little bit of those, what we were trying to drive at in the subdimensions, and then Rick and I will kind of pepper that with a little bit of our own experience in each of these. The first of which obviously here is strategy and culture, and that really drove questions around organization, governance, and leadership. And I think that on the organization side, there's some just key questions to be answered around how you want to organize yourselves, kind of legally as an organization on a corporate structure, and what kind of partners and how do you want to do that in a way that supports, sort of your end outcomes. And for us, I think as Ascension, we were committed to building a pretty big tent. And so as a organization, we wanted to really engage not only our employed providers, but our affiliated and community-based physicians. We wanted a structure that would engage both primary care and specialists. When we looked across the country, there are a lot of, I would say, loosely ACOs or value-based care initiatives that are only focused on primary care and only with their employed physicians. And we felt that, patients are seeing a wide array of physicians for their diverse set of clinical needs. And if we were going to be successful, both in improving clinical outcomes and taking risks, that we were going to have to build a big tent. But I think that's a critical question for folks when thinking about the organization and the partners that they want involved. That, for us, then drove governance. So obviously, we wanted representation from those various constituents, both inpatient, outpatient, and employed, affiliated, to really make sure that we were meeting that broad mission and that inclusive structure. And that's boded very well for us. It's brought a perspective of opinions and diversity of thought to make sure that not one initiative is favoring one constituent over another. We have, however, done that organization and governance at a regional level to take advantage of participation on the local level, and to be able to morph the wider kind of governance model to any kind of unique needs that we see in a given geography, but decided to kind of execute against the day-to-day operations through a new piece of infrastructure. So instead of having the operational structure that was both taking on the risk and managing the risk at each of the regional levels, over time we have developed what we call Ascension Care Management, and that has really become the predominant vehicle for us to operate, on the ground in each one of these geographies, visiting patients in the hospital, visiting them when they get home, and doing any follow-up care to be the glue between their traditional clinical interactions. And so we've taken a Big Ten approach to organization. We've aligned governance at a regional level, and then we've built new infrastructure that was scalable at a national level to really bring executive and clinical leadership dedicated strictly to value-based care and value-based care agreements, and to ensure that as we get smarter at this, that those best practices spread quickly across our enterprise and the country that we're located. Rick, anything to add here on the strategy and culture dimension?
Yeah, that's great. That's great, Jason. I think we can provide a contrast to folks. Interestingly, I think a couple of early on decisions we made. Our first go around was to say we wanted to have a separate ACO, SSC ACO in every market, by 1/1/15, and we got pretty close. I think we had like 15 of them. So then we realized, oh my goodness, it's really expensive to run 15 separate ACOs. And maybe as we've gone along, we've actually realized that, we've built a couple now national ACOs that have chapters. So that was an important learning for us. We think so far that's worked okay. So we have local chapters as you described, but we've also rolled them into national ACOs for purposes of Medicare. Commercial is still handled separately. We found that also provides a nice, larger population base, better stability, we hope, in benchmarks, et cetera. So that was, I think, one early learning that we had. The other decision we made was to actually operate these very specifically through our regional health ministries. We are made up of 18 regional health ministries, that is, integrated health systems with that have doctors, hospitals, in many cases, home health, and continuing care, SNF, et cetera. And so we made a decision, and this is a little bit probably counterintuitive maybe, but we made the decision to actually create a system capability that included technology, data infrastructure capabilities, and expertise around managing populations. But we delegated all of that work, not delegated, but we left it with the regional health ministries, and we sought to build that new capability into our existing regional health ministries. This has been, we thought there were some good reasons for doing it that way, and we're continuing to live it out, I would say. But as I think everybody can imagine, convincing a existing integrated system, fee-for-service integrated system leadership team to adopt population health as one more key piece of its portfolio of operational activities. It's not natural, and it's not easy, and we think there's good reason to do it, but it remains to be seen, I think, how well that delivers in terms of results. We, like Jason described for Ascension, we did go broad with our network, so we have about 14,000 physicians out of a total of 24,000 physicians who operate in our various hospitals, who work in our hospitals. Not only 20% are employed, by the way, but we went broad so that our clinically integrated networks that were established to support our ACOs are similarly made up of primary care specialists and other providers. So I guess I'll stop there on this dimension.
Great, Rick. I think that's a great segue to kind of our next slide here on structure and investments dimension. And I think the task force really, centered on kind of the three subdimensions of infrastructure, workforce, and business focus areas. And I think, just to unpack each one of those a little bit, infrastructure, I think, is a real challenge because in some ways the new entity targeting value-based care is going to require new infrastructure to do some of the more unique kind of risk-taking and patient management and patient surveillance. At the same time, that infrastructure is highly dependent on the existing infrastructure, whether or not that's connecting to the hospital EMR or a physician-based electronic record. And so, I think that one of the key elements that were best practices identified by the group was, you need to be willing to invest in new infrastructure that's going to, for instance, help, risk stratify the members that you're serving, have a workflow for the nurses and allied health professionals that are reaching out to those members on a daily basis. But then that infrastructure has to be interfaced with traditional elements to get the data you really need to succeed, which is being able to ingest payer data as well as clinical data from EHRs and EMRs. And I think that the infrastructure is really needed to kind of support for lack of a better term, the job to be done. I think the market has really evolved over the last 6 to 7 years in terms of what infrastructure is available. But at the end of the day, the key infrastructure that we've defined is you really got to have a technical infrastructure that can create a data lake of information about the members you're serving. And then that infrastructure needs to help prioritize, people who need help today. And they also need to identify those that are rising risk to prevent, further issues occurring. In addition, I think one of the things that this effort has also shown is a real drive towards understanding the social determinants of health, and more in being able to ingest that data, but also building partnerships with those other parts of the infrastructure, whether or not that's, working with your nonprofit organizations to address food deserts that are in your community or unique behavioral health needs. I think one of the real learnings from this work by not only ourselves but others in the industry is that we need to think broadly about the community infrastructure and the importance that they serve to improving the health care of and the wellness of the members we serve, but also then being able to connect to them in material ways. That has then informed kind of the workforce that's required. And I think we have found that in living into this sort of value-based world, that you not only need to ensure that your traditional workforce involved in physician practices or hospitals is committed and aligned, but you've also are tapping into behavioral health professionals and social workers and others that are going to help unearth other challenges that these members are facing. And it is not uncommon for us now to be working on food access or access to affordable housing, transportation, issues that we've now shown to be statistically significant in determining health outcomes, but have traditionally not been elements that the healthcare industry has been focused on in a traditional fee-for-service environment. And so I think one of the best practices that was identified by the task force was thinking more broadly about the workforce, and then being sure to develop models where infrastructure and workforce fit inside distinct economic models. And I think one of the real learnings is that, CPC Plus behaves a lot differently than MSSP, which behaves a lot different than your commercial risk payments. And because of that, you've got to be able to tailor the right infrastructure and the right workforce investment inside the unique economics that sit inside these different contracts. And even more challenging, as many of you know on this call, is that those economics are different by geography. So, for instance, your MSSP baseline is going to be very different in Detroit than it is in Birmingham, Alabama, or Indianapolis, Indiana. And so another best practice that was identified is you've got to be able to kind of titrate your infrastructure and workforce to work within kind of the unique economic constraints of your different contracts or agreements. Rick, what am I missing on this one?
Well, I not a lot, but I don't think, but I would double down on the workforce issue in this way. That industry has had a lot of experience over the last 7 years, and we've been through permutations on, all sorts of technical aspects of both, the financial side of it and as well as the care delivery side of it. And I think rule one on the workforce needs to be don't try and hire people who've been through it. Don't steal any of our stuff. But I would urge you to, this is not the job for the person who used to be running, the radiology department or the ER to start out. You need to get people who have had the experience of what we've gone through over the last couple of years. So number one, I'd say at a leadership level and kind of the next tier down, look for people who have been through the battle so far already, and import, one way or another, import all the knowledge that has been built over these last several years, because it's a lot. Then I would go back on the infrastructure point again and say, there's a lot of degrees of sophistication, and depending on what work you're doing, whether it's in the Medicare SSP arena or bundle payments, or in the commercial space or in the Medicaid space, the needs will be somewhat different, but there's a few basic things that a smart, experienced, trained team can make a difference with claims data. I will just say that, from the get-go. And there's a lot to be done in an SSP environment, for instance, using the claims data and using an analytical tool that can do the predictive modeling. And don't feel like you have to have the world's most sophisticated predictive modeling capability. The reality is there's not that much difference, and there's lots of tools out there. The key is not so much, you got to have a tool, you got to have the claims management capability. You'd like to have ER data going with it, but it's not essential to get going and to be successful. But the most important thing is you got to produce analytical reports that are simple, that, as Jason said, can be integrated into workflows. The most critical piece, and I think the piece we see where we've had the most difficulty to be effective, is in hiring people to actually touch patients, and then training people to actually touch patients. We've spent a lot of time with medical directors wringing their hands about why they don't have exactly the right kind of data. But the reality is they have the right kind, oftentimes don't have the right kind of patient, nursing or social workers that can actually touch a patient and make a difference in a patient's life. So get your data needs met at a minimum level to begin with. Don't over-engineer it necessarily to try and have lots of clinical pathways and AI and all that built into it from the start. Just get data, hire people who know how to manage patients' experience, how to interface with the delivery system, get enough people to actually go out and touch people. And I believe the one mistake we have made as an industry, well, two mistakes. One, the opportunity for providers to earn a return are not as good as they should be, I believe. And I say that even when I was wearing a CMS hat, we need to make sure that there is an adequate opportunity for returns. And correspondingly, we need to, as provider systems, we need to make investments. We can't kid ourselves and think we're going to hire one nurse for an ACO of 30,000 people and we're going to be fine. The reality is you have to hire sufficient numbers of people to get out there and touch people with enough frequency to change their lives and make a difference in care delivery. And so I would urge you to pay a lot of attention to understanding staffing models, training people so that they have the ability to reach out and touch people, and then give them the infrastructure they need to find those patients. But don't spend all your time worrying about data being perfect. Spend more of your time worrying about whether or not you've got people effectively touching patients.
Well said. Well said. And I think hopefully you're getting a sense of how these different dimensions kind of hang together and support one another. And I think, you know, structure and investments really goes hand in glove with kind of operations and accountability here on the next slide. And I think when we thought about these subdimensions, we were really now focused on, you know, kind of where the rubber meets the road. And, you know, if you think strategically about building a big tent, having a strong, diverse representation at the governance level, and then you think about building out a collective infrastructure and a workforce that supports that wider kind of physician, hospital, community-based organization, then it becomes, okay, how do you now align them all? And how do you make sure people are held accountable? And I think this is where we saw a real diversity of ideas and practices inside the task force, and it would make sense that that would be the case based on sort of the makeup of your particular value-based organization. And I think just to lightly touch on each of these, operational alignment, you know, one of the things that we did is, as Ascension, we actually went out and papered our networks. And so we wanted to have inside each of our participating agreements with, you know, both physicians, facilities, and, you know, post-acute care settings and home health agencies, that we would both have a financial and operational alignment. And so operational alignment occurs around sharing information, agreeing to regular training and education, participating in planning and execution. And so one of the things that was also very helpful is when we thought about alignment, we aligned around problems we wanted to solve, as opposed to the traditional ways in which healthcare is typically aligned. So, you know, we don't have necessarily groups focused on cardiology and orthopedics and pediatrics. We have folks for coming together around obesity, asthma and airway, you know, these things where you can get a primary care and a specialist and a pediatrician, as well as you know, facility partners coming together, looking at the data, solving for the real healthcare challenge in the community, which opens up new possibilities, it opens up new ideas, and quite honestly, it drives a level of innovation that wouldn't occur regularly in more of a more homogeneous sort of group or setting. But obviously people need to be incented to kind of drive that change long term. And so for us, and I think this was pretty consistent, a number of value-based care organizations still operate on a fee-for-service basis. Most organizations are having people drop a claim and paying them, but they are rewarding them on the back end for management of that population writ large. And so there's significant upside in terms of shared savings. But I think in the case of Ascension, we took financial incentives a little bit further in that we agreed that we would pay, for instance, primary care a bonus if they had a way to securely email with their patients, if they extended the number of hours during the weekdays and weekends. And so you begin to sort of see, okay, if we can incent kind of some operational changes, we'll get better outcomes. And so having the ability in your agreements to think more broadly than a traditional kind of fee-for-service payment into maybe a regular payment for some operational changes and some long-term upside for supporting kind of the wider initiative across the population seems to be a growing best practice kind of bubbling out of both experience and literature, all really in service to better outcomes. But I think that when we think about quality measurements, we have to think pretty broadly. So some of those are clinical in nature, and some of them are in service. And so I think good value-based organizations, they need to remain focused that clinical quality is kind of table stakes. It needs to happen. It needs to be successful at every level. But I think quality, as we discussed as a cohort, started to take on new dimensions of service and service delivery that traditionally we may not have considered, but is becoming more and more important to our commercial partners that want to make sure that people can find a physician easily, get into the physician easily, that the network is broad enough that they have a choice of providers. And so I think the one asterisk I would put around this subdimension is that we mean quality kind of writ large in this case. And a lot of times that requires building infrastructure to take on and manage data that traditionally hasn't been present in the health system. Rick, what else do we have there?
Well, interesting. On operational alignment, again, we're coming from a world where we have integrated our value-based work into our traditional health ministries with hospitals and doctors and home health care organizations. So aligning kind of objectives for the traditional organization has been a challenge, quite honestly. It's been a real learning. It's even though you might think from your system office that there's all good things happening out there, the reality is that people are busy delivering care and taking care of real sick people, and this is not natural work for them. So we've learned you just have to constantly stay at educating folks coming who are not from the value-based world, educating them, talking about some of the specific areas of non-alignment, like, oh my goodness, you want to reduce readmissions, and gee, and what's that going to do to my overall, success of my hospital? And those kinds of issues are very real. They come up and they need to be surfaced and addressed and discussed, not once, but frequently. We found over the years they keep coming back because financial incentives tend to be operating around financial performance, and we need to get incentives related to value production on a level footing with other kinds of incentives that have existed historically around hospital quality only, for example, or hospital margin, et cetera. So I think you have to really pay attention to this and work at it constantly. The other thing we interestingly did was one group started working on episode-based care, and another group started working on ACOs. And we purposely did that because we knew we had to start up these new care models to be successful under these respective programs. But then we realized, of course, that there's a lot of commonality, a lot of management of post-acute care, which is very common across those programs and other programs. And we realized, oh my goodness, we've created a couple of silos. And so we've been working hard to try and bring the care management function together, not just in our value-based products, but our programs, but also with our traditional care management within the hospital, and to the extent that it existed at all in our primary care practices. So trying to create an integrated care coordination approach, we found was an opportunity that we created along the way. The last thing I'd say is, it's very hard for value-based people to have the perspective of running a hospital, and it's very hard for hospital experienced people to understand the details of these models and these value-based models. And that goes to both the quality side and the financial side. So I think constant education and discussion and feedback on a regular basis, a weekly, monthly basis, to look at outcomes is really important. And it does not come natural to people. People will nod their heads, but I think what we've learned is that we need to go back time and again and have more frequent and deeper conversations with folks to help them understand the part of our new world that they are not familiar with.
Yeah, I think, before just quickly transitioning here to the next slide, I think Rick brings up some really exceptional points, and I want to just connect the dot between the earlier statement of community-based organizations and social determinants of health. I think that, the real progressive players around the country are thinking about their community-based organizations similarly that they think about their facilities and physicians. And what I mean by that is we're seeing a number of folks actually contract with community-based organizations for discrete services like you would in a fee-for-service arena. We're seeing others allow them to participate in the shared savings profile for distinct populations. So I'm thinking of a Medicaid agreement in a certain geography where the community-based organizations get to participate alongside the physicians around the total shared savings. And then I think you're also seeing some accountability occur as well on both the quality and the operational side, where they are equally held accountable for certain quality outcomes. And so I think, some of the innovation around operations and accountability is also designing new ways to align and financially incent those that aren't kind of traditionally in what we would consider the healthcare ecosystem, but are pretty material to it. In the interest of time, we'll move on to kind of the last dimension here, which is actually performance management. And the two subdimensions here are kind of process and outcomes evaluation and financial modeling. I think this is pretty straightforward. I don't think it needs a lot of explanation. I will say that one of the real learnings has been that how much differentiation there is in both of these by lines of business. We were very surprised at kind of the difference in both spend and expectations on our commercial risk contracts than we had on Medicaid agreements, than we had on Medicare agreements. And then you've got MSSP and you've got NextGen and other forms. And I think that the real takeaway from sort of this task force was that you really got to be sensitive to the unique operational quality and financial outcomes by line of business. So you may want to be thinking about yourselves as, the value-based organization of choice, but your long-term viability is really going to depend on your ability to titrate your resources and investment to the line of business to get the greatest outcome. And I think that, underscoring that is obviously investing in the data infrastructure to be able to monitor that in real time. I think one of the real challenges still is getting real-time enough data to be proactive. One of the real sort of shadow issues that shows up under value-based organizations is the just sheer lag in information that organizations get from payers, and how unorganized or unstructured a lot of the clinical data is. So when you get started in this work and you're trying to monitor your progress around outcomes and evaluations, being able to do so proactively is a real challenge, and I think shouldn't be underestimated. and consequently, your financial modeling is going to take a while to take shape, because you're getting some of your data 90 to 120 days after it's occurred. But I think, we as a task force really felt like performance management was its own dimension. It was an area that needed a discrete amount of focus. Successful value-based organizations are spending a lot of time and energy on this dimension, and I think are getting more and more sophisticated on their sort of financial modeling. And I think one of the things that will be interesting is as the new kind of more full risk scenarios come into play, can value-based organizations really pivot to paying people differently based on what they're seeing in their data and their financial modeling? And I think that's an open question, but I think it is an arena in which the providers are really keen on in transitioning from a traditional fee-for-service to a fee-for-value world. But as I suspect, at the epicenter of probably the next webinar, which is how are the payers thinking about supporting this effort? So, just in the interest of time, Rick, any parting thoughts here on this last dimension?
I agree with what you said, and I guess I'd add, it is important to drive data back in to develop a disciplined way of looking at information, even if it isn't perfect, and it won't be perfect. So I think it is critical to have a regular reporting cycle of demonstrating what's happened with ER visits, what's happened with readmissions, what happens with your SNF length of stay, what percentage of patients are going to SNFs. Those kinds of metrics on a weekly, monthly basis are the key to success. The tighter your cycle time around feeding back meaningful metrics, the more successful the organization will be. And then developing a P&L, and it's really hard to do a P&L for a lot of reasons, at least in a large organization like this, for this business. But going through the disciplined process of figuring out what a P&L, what a profit and loss statements look like for this line of business, I think is important and will lead you to a much better understanding of the operations, and will help you train your team to think about this very concretely as a business, in addition to the right thing to do, rather than just a program.
Excellent. All right. Well, on that note, let me hand it back to Jeff.
Thanks, Jason and Rick, and great information. We always tell people from the task force perspective that this is hard work. It's an iterative process, and the investment and the realization of a return takes time. And clearly, your lessons learned and examples shared kind of prove that point. So we do have a few questions, and I'll pick up one here that we touched upon social determinants of health a few different times. And Jason, you came back to it to talk about partnering with community-based organizations. We have one attendee who is really excited that we did talk about it in the context of infrastructure, but further asks the degree to which payers or state and local governments kind of get involved in partnering and financing on the social determinants of health integration piece. Any thoughts about that? Any experience?
I think we do see pockets of foundations and certain federal agencies willing to support, what I would call kind of infrastructure grants to facilitate that level of collaboration and engagement. But I think that one of the real challenges is that a lot of these community-based organizations don't see themselves as supporting the health infrastructure, and so they either don't think about themselves as qualifying for those monies, and sometimes we don't identify them as key stakeholders. And so, I think early on, we saw a lot of that work. I see less and less of it now, but I think at the same time, we're seeing more organizations think about contracting with those organizations, as I mentioned earlier, or allowing them to participate in upside given their engagement.
Great, thanks. And we do have another question. And Rick, I'll pose this one to you. Obviously, you're looking at it from a provider perspective now. You have a payer perspective in your background, and you also have the public perspective from your time at the Innovation Center. The question here from one of our attendees is, can you discuss what you think are the most meaningful opportunities for public and private collaboration and alignment to promote value?
Yeah, thanks, Jeff. I think it's a great question. It's vital. It's important on so many different dimensions for us to look for those opportunities and really seize them. I would hope that under some of the state innovation model grants in some states, they have done a decent job of pulling together providers, payers, patient advocates in their locale to actually search for a common way of rewarding and a common way of measuring quality, a common way of measuring cost, and a common way of rewarding folks who deliver it. So I think it's incumbent upon all of us to try and, in our local markets, reach out and ask for states to come to the table with private payers. And I think, Medicare can come, and I think urging Medicare to do more in the way of multi-payer arrangements would be a wise thing for all of us to do and for the task force to do. But I would urge folks to talk to their states, particularly if you're in a state with a SIM grant, and talk with them about facilitating the coming together of payers and providers to try and develop common approaches. We're only at about 25% in terms of our target of 75%, in large part because we can't get as many payers to participate in these models as we would like to. And one of my hopes was that states would be much more active in encouraging that. So I would urge people to reach out to their states and see if you can get more help there to encourage people to come to the table and look for common ways to work together.
Great, thanks, Rick. And so we have time for one more question, and this is a kind of more of a targeted question, cutting across a few different dimensions. The question is, does remote monitoring have a place to complement staffing and workflow for patients in their homes?
Yeah, I think it certainly does. I think we're early. I think we as Ascension are playing around with a number of technologies in this space. I think that the challenge is just making sure that the right technology is measured with the right demographic. And what I mean by that is, we see it especially helpful when a member is living alone as opposed to with a caregiver. I think the other is really helping educate these technology partners around the economics and helping them develop pricing models that work within a value-based care environment. And so I think you're going to see a rapid evolution of this based on our own understanding of where the technology is best used and the partners and vendors' understanding of the best way to price it for broader adoption.
Hey, Jeff, I would agree with Jason. I think, it's interestingly at CMS, they did a number of evaluations of different remote monitoring programs as a standalone, and just by themselves, they didn't demonstrate any impact. But in the context of an organization managing the triple aim for a population, I believe now we're seeing evidence that they can have significant impact. And I would say it's like any technology, you have to make sure that it's ultimately wired up to an effector arm that understands that their job is to deliver the triple aim and therefore manage total cost and pay attention to it. And therefore, you can't extend every modality to every patient. You have to decide, as Jason describes, what's going to make a difference for what population, and be rigorous about pursuing it in those situations. And I think if we do that, there actually will be some significant change in the way we deliver care and lower costs and better outcomes.
Great. Great feedback. Both of you think that. So we've now reached kind of the end of our hour, and want to just quickly tell you that, remind you of a partner webinar, The Transformation to Value, a Payer Perspective, on November 2nd from 4 to 5 p.m. Eastern Time. We're excited to have Kevin Klobuchar from Blue Cross Blue Shield of Michigan and Bridget Nettesheim from Aetna to join us for that dynamic and candid conversation. And you'll also see on this slide that we have two upcoming webinars in November, December that will be focusing on a separate task force product that we'll be issuing next month on identifying the levers of ACO success. So really focusing on within the model of accountable care, what has been successful for those ACOs that are within our membership, but also beyond our membership. So I'd like to just close out by just a huge thanks to Jason and Rick for their time and their insights on today's call. We will post the materials from this presentation along with a recording on our website within the next 24 hours. You'll be able to access that by going to www.hcttf.org. We will also receive a short survey via email in the next 24 hours. We really wish for your feedback. We want to make sure that we're providing value in these webinars and that we answer your future needs. We certainly hope you will participate in future webinars, and thank you and have a great afternoon.